We're going to talk about valvular disease, and this is overview of the pathophysiology and treatment of patients with valvular heart disease, including there's some recommendations from the American College of Cardiology, American Heart Association that we will go over. The full page is more than 100 and some slides, so we're not going to go through that. We're going to just talk about the valvular heart disease, pathophysiology and treatment, and then treatment guidelines according to the 2016-2017 guidelines. So again, anatomy of the heart valves, we don't need to review that. You've all had anatomy, but we're going to talk about each in the context of stenosis and regurgitation. Again, valvular disease, it's getting worse because, we have more and more aging population, people living longer, so you're going to see more patients with aortic stenosis and just valvular disease in general. This is a big recommendation. So if you have a patient that has severe valvular heart disease, they need to be evaluated in a setting where there are center of excellence. So asymptomatic patients with severe valvular heart disease, patients who may benefit from valve replacement. So you want to get them into the setting quickly as you can. So if you're not at a center that does have a valve heart team, you need to get them to a center that does. So rheumatic fever, again, 1 per 100,000 school-age children in Costa Rica, more in China, not really here in the US, because we do have aggressive treatment of infections here. So what could go wrong with valves? Stenosis and regurgitation. Stenosis is narrowing, regurgitation is insufficiency, so backflow against the valve. Stenosis causing obstruction of the flow out of the valve. Types of valvular disease, obviously we've got regurgitation and stenosis in each valve. Really, when you talk about treatment, you treat them from a surgical standpoint differently based on the severity of stenosis, regurgitation, and symptoms. So we'll talk about tricuspid regurgitation first. So backflow into the right atrium as a result of deficiency in the tricuspid valve, typically caused by either an abnormal valve or tricuspid valve prolapse. Could be secondary to carcinoid plaque formation, collagen disease, valvular tumors. Usually here systolic murmur, although it may not be present, and S3 may be accompanied by the murmur related to the high flow of returning into the right atrium. So treatment, mild tricuspid regurg is common, generally managed with diuretics. Treatment depends on the cause. Treatment of pulmonary hypertension may also reduce the right ventricular size to treat the tricuspid regurg. So if you remember, whenever you have issues with heart remodeling, you have shifting of papillary muscle and valves that can cause regurgitation. So treating the underlying cause and reducing that size of that ventricle could help manage patients. Tricuspid surgery, often done in conjunction with other valve surgery. It's usually not done by itself. The valve can be removed temporarily when treating endocarditis, but it is rare, must be replaced within 3 to 6 months. So shifting to tricuspid stenosis, much less prevalent than mitral stenosis. It's typically due to rheumatic disease. In the US, it could be due to tricuspid repair or replacement. So tricuspid stenosis, you may have a diastolic murmur. EKG shows right atrial enlargement, tall peak T waves. Chest X-ray, usually you're not seeing much in the way of X-ray. Echocardiogram, best way to diagnose all these valvular abnormalities. Pulmonic regurgitation, it's rare. Typically, little hemodynamic significance, can be congenital or acquired. The most common acquired abnormality is secondary dilatation if the pulmonary ring due to severe pulmonary hypertension. Pulmonic stenosis, a dynamic or fixed obstruction of the flow from the right ventricle of the heart to the pulmonary artery, usually diagnosed in childhood, may occur in association with complicated congenital heart disease, so requires surgery depending on the degree of severity. Not really common in adults, usually in pediatric population or adults who've had congenital heart disease as a child. Mitral stenosis, narrowing of the mitral valve as a result of obstructed forward blood flow. Etiology, rheumatic endocarditis from fever is the most common cause. Approximately 2/3 of the patients are female. Patients usually are presumed to have an underlying rheumatic heart disease. Valve leaflets thicken, mitral tissue becomes fused together. The narrowing opening prevents normal blood flow from the left atrium to the left ventricle. The left atrial pressure increases and dilates the left atrium. So characteristic finding is an opening snapped followed by a A2 due to a stiff mitral valve. So the mitral valve stenosis worsens. There's localizing diastolic murmur and a low pitch. The murmur is best heard at the apex of the patient's left lateral position. Symptoms: fatigue, dyspnea, orthopnea. So you could have mild to moderate stenosis, or in severe stenosis, there's severe pulmonary hypertension develops due to the secondary stenosis of the pulmonary vasculature. Symptoms are low cardiac output and right heart failure. And mild to moderate stenosis, the patient can be asymptomatic or just symptomatic with exertion. Echo findings: enlargement of the left atrium. Patients who are symptomatic typically have a valve area between 1.3 and 1.8 centimeters squared. Treatment depends on severity, typically a valvuloplasty or an open mitral commissurotomy. So, basically where they go in and stretch that valve or cut the muscle around the valve to lessen that stenosis. Other diagnostic testing: TEE, EKG, chest X-ray, cardiac cath. Valvuloplasty for mitral stenosis, they use a scoring system. You want more information on this, you could also look at the American College of Cardiology, American Heart Association guidelines for this. From a pharmacologic standpoint, diuretics, digoxin, patient has atrial fibrillation. Mitral regurg, definition, backflow of blood into left atrium causes a deficient mitral valve closure. Etiology, inflammatory, infection, structural or congenital. Patients can be asymptomatic for years, may cause left atrial enlargement. Degree of left ventricular enlargement reflects the severity of the chronic disease. So symptoms: fatigue, weakness, dyspnea, palpitations. Physical exam, they usually have an S3. Sound: systolic murmur, left fifth intercostal space, midclavicular line. Acute versus chronic mitral regurg. Acute causes endocarditis, myocardial infarction with papillary tendon rupture. Chronic, secondary to heart disease, hypertension, mitral valve prolapse. Untreated syphilis, Marfan syndrome, or rheumatic heart disease. Again, signs and symptoms: sometimes patients just present with acute pulmonary edema if they've had a MI, or sometimes it's just exertion. Diagnostic testing, again, echocardiogram, EKG, chest X-ray. Management, so vasodilators, digoxin, and possible anticoagulation if patient has atrial fib. And there's a slide at the end that does go over that a little bit more detail. Diuretic therapy, antibiotic prophylaxis for dental procedures, surgical replacement of the valve or door procedure. So mitral valve prolapse, again, protrusion of the mitral valve in the left atrium during systole as a result of damaged leaflets on the valve. It's usually benign. 20% of the population has this, more prevalent in men than women. On auscultation, there's a typical mid-systolic click. Again, patients usually asymptomatic with this. Diagnostic testing, same for mitral disease. Management, similar to mitral valve disease, but again, most of the time it's just monitoring. And most of the time patients don't need additional follow-up once this is diagnosed if they're asymptomatic. Now, looking at aortic stenosis, this is a much more prevalent valvular disease, especially as we age. Patients will develop aortic, a lot of times will develop aortic stenosis. So it's a narrowing of the aortic valve resulting in obstructive forward blood flow. Etiology, rheumatic heart disease is most common cause, aging, idiopathic calcification of the aortic valve, or a congenital bicuspid aortic valve. Most common valvular disease in the US. Aortic stenosis, so you have a congenital abnormality or you have a calcified valve or degenerative valve. Congenital abnormality, abnormal unicuspid or bicuspid valve may be present. Bicuspid aortic valves present in about 0.5 to 1 and 1.4% of the general population. Patients are usually asymptomatic until they get into their 50s. For a calcium valve, usually related to calcium deposit, similar to atherosclerotic valvular disease, usually worse as people age. So aortic stenosis prevalence, about 25% of the population over the age of 65, 35% of the patients over 70. About 10 to 20% of these will progress to hemodynamically significant aortic stenosis over the next 10 to 15 years. Symptoms, dyspnea, angina, syncope is a big one, especially in severe aortic stenosis. Physical exam, I think it's the easiest valvular abnormality to pick up on auscultation. Systolic rush, rough, harsh murmur at the second right intercostal space. In severe disease, you can have heave or thrill, weak to absent second heart sound. It's really a loud murmur normally. Again, tests, echocardiograms, the gold standard, TEE for definitive valvular area. Again, this is just showing the guidelines for severe aortic stenosis. So, and I have a couple other slides that talk about this. So when the valve area is below 1, it's a severe aortic stenosis. I think that's something to commit to memory. You know, you'll look at a lot of echoes and they'll say moderate to severe aortic stenosis. You need to see what that valve area is. If it's less than 1, definitely needs evaluation by a valvular specialist. Then also looking at the velocity and the mean pressure. So if the maximum aortic velocity is greater than 4, so it's a lot of pressure coming through that valve, or the mean gradient pressure is greater than 40. Critical aortic stenosis is less than 0.6, but those patients are usually severely symptomatic at that point. So this is just the American Heart, American College of Cardiology definitions of severe aortic stenosis. You don't need to memorize this, but just understand that they have stages based on risk. So if someone has a bicuspid aortic valve that doesn't have really any clinical symptoms, they're at a stage A, so you want to intervene early so they don't develop any worsening aortic stenosis. Stage B, they have some, again, have no symptoms, but may have some early diastolic dysfunction. So you're intervening with pharmacologic medications, lifestyle changes. And then as we get stage C is symptomatic or severe aortic stenosis. So looking at valvular anatomy, they have significant calcification, reduced leaflet opening. And you could see that now we're looking at, the valvular area less than 1, and they have symptoms. So sometimes in C1, they have just some exercise-induced symptoms. C2, you could see they have some hemodynamic compromise with left ventricular EF less than 50. And then D, your symptomatic severe aortic stenosis. So they have exertional dyspnea, angina, they can have syncope or pre-syncope. So again, sometimes they'll list an echo or cardiology will list in their valve report that the patient has D1 aortic stenosis. So what does that mean? That means, they have a significant abnormality with an less than 1 centimeter squared valve area and have symptoms: exertional dyspnea, angina, pre-syncope. And then it goes as high as D3, which patients having heart failure from it, angina, syncope, along with the reduced stroke volume, restrictive diastolic filling. These are patients that you don't want to drop their preload because they have such poor flow forward that they can cardiac arrest if you drop their preload low enough. So again, management, valvuloplasty. Valvuloplasty is okay, but again, it's usually short-lived. Surgical replacement of the valve, either with traditional open valve replacement or TAVR. Symptomatic treatment, you want to decrease preload. Again, excessive decreasing preload should be avoided. These patients should have some antibiotic prophylaxis for dental procedures, as we talked about in our endocarditis lecture. And this is just indications for valvular replacement. So if you look, you don't need to memorize this. This is just for your information only. This is looking at patients with severe aortic stenosis, if they're symptomatic, not symptomatic, what stage they're at, and their evaluation for aortic replacement. And this is a choice of a TAVR versus a traditional aortic valve replacement. So if you're they have severe aortic stenosis, stage D, they have low surgical risk, medium, or high, and looking at which patients then get into the traditional aortic valve versus a TAVR. Looking at aortic regurgitation, backflow of the into the left ventricle as a result of deficiency in the aortic valve leaflets. Etiology, again, rheumatic fever, infectious endocarditis, the most common acute presentation. Presentation usually fatigue, dyspnea, syncope, S3 heart sound, a blowing diastolic murmur heard over the third left intercostal space. Signs of congestive heart failure, increased pulse pressure. Again, testing echo, either transthoracic or a transesophageal. Management, surgery, vasodilators, you treat their CHF, antibiotic prophylaxis. Again, just some talk about valvular surgery, increased perioperative mortality rate associated with advanced age. So again, we're stratifying if it is the aortic valve, or can we do mitral valve repair if it's secondary to mitral versus a traditional valve replacement. So tissue versus mechanical valve. So tissue valve, 30% at 10 years, 50% at 15 years versus a mechanical valve. These are just some examples. That's just an example of an artificial valve. Annuloplasty rings. So sometimes if we can repair those valve with a ring, it's a little less invasive for the patient. This is the artificial St. Jude's mechanical valve. And then artificial tissue valve. And then the last thing is, talk about the transcatheter aortic valve replacement, TAVR. There's a video on this if you want to take a peek at it. I'm sure many of you have taken care of these patients. They tend to do much better from a valve replacement standpoint than a traditional open heart surgery. And then this is just to talk about anticoagulation. So this is new in their 2019 guidelines. So anticoagulation is indicated for patients with rheumatic mitral stenosis and atrial fibrillation. You want to use a vitamin K inhibitor. So that warfarin anticoagulation is indicated in patients with atrial fibrillation and a CHAD2 score greater than 2, with native aortic valve disease, tricuspid disease, or mitral regurgitation. So these are some new guidelines for anticoagulation. This one is also we haven't seen usually a oral anticoagulant is reserved for atrial fibrillation without valvular abnormality. This is saying it's reasonable to use a oral anticoagulant like Pradaxa or one of those in patients with atrial fibrillation with aortic valve disease. So it's something new that we haven't seen before. So these are, again, some new recommendations. And that's it on valvular heart disease. If you have any questions, please let me know.